Alrighty. Hello, friends. Welcome to another review. I feel like I'm a YouTuber every time I start these, like I never know. Anyway, welcome to your first review for Exam 4. Today I'm going to be talking about burns, everything you guys need to know for Exam 4 about burns. Really quickly, I just want to say I've had a couple people reach out and ask how Exam 4 is compared to your other exams, and even though I know for a fact it was not the hardest exam, I'm probably not the best person to ask. So musculoskeletal, all that fun stuff, Exam 4 was my best exam. I only missed one, but I greatly attribute that to my experience as a tech because I've worked on ortho for like the last year. And so pretty much all of the musculoskeletal stuff was second nature to me and stuff that I'd either done or seen at work. But yeah. But anyway, that being said, I do remember like most of my friends got A's and B's on this exam, and like I remember going through it and being like, if you studied, I think you're gonna do fine. Like if you guys have been studying consistently, it's nothing that you haven't covered before. And I don't know, I just feel like the questions weren't as tricky. Like, I don't know, but anyway, so I will do this burns review, I'll do a musculoskeletal review, and then I will do a critical care review, even though there's not much with critical care. But getting into it, so burns are very important. Burns are one of those topics that you guys are going to see and going to like continuously follow you as you study for the NCLEX. So like, I don't know if any of you guys have started studying or doing some practice questions here and there, but I know for me, like, I haven't even studied that much yet, and I definitely have seen burn questions. So, like, it will pop up, it will follow you. I would say the exam, you don't have, like, a ton of burn content on this exam. There's just a couple things, and I feel like most of it is related to, like, nursing interventions and what you do in the different stages to promote healing for your patients. So, if there's one thing that I really think you guys need to understand, it's just, like, the nursing interventions, which we'll talk about. So burns are really important because they obviously can cause lots of complications. So we can have like hypothermia, scarring, body image issues, immune system becomes compromised because your body's trying so hard to heal, fluid loss, and there's a really big infection risk. So looking at the types of burns, this is the first thing that you guys definitely need to know for the exam. I am trying to remember, but I feel like we had a select all that apply, and it was like about one of the burns, and we had to select all of the options that applied to that burn, if that makes sense. So first burn we have is superficial, so that's your first degree burn. So these are going to be super painful because they're superficial, so we have a lot of cell death on the superficial level. Really painful, no edema, they're going to be pretty red, and it's going to blanch with pressure. So I was sunburned, but I'm not anymore, so I could have showed you guys. But basically, if you think like if you've ever had a sunburn, if you press on it and it just like turns white immediately, that's what that means, blanches with pressure. And so this is damage to the epidermis. And so if you guys go back, way back to A&P, and you remember your layers of the skin, remember you have your epidermis, epi means on top, your epidermis, your dermis, and then your, what's that called? Like adipose tissue at the bottom. So yeah, so superficial, just remember they're really painful, no edema, redness, and it blanches with pressure, and it's damage to the epidermis. So your partial thickness, you can have two types for partial thickness. So it can be first degree burns if it's a superficial partial thickness burn, and it can be second degree if it's a deep partial thickness burn. So with your partial thickness burn, you're gonna think blister. So these are the burns that you're gonna see the blisters. They're gonna be moist, gonna be painful once again, and then they're going to damage the epidermis if it's that superficial, and it's going to damage the dermis if it's deeper. So blistered, moist, and painful. And then full thickness, so these are your third and fourth degree burns. So with these burns, they're going to be really dry, discolored, and there's going to be no pain, which I always thought was interesting, but if you think about it, these burns are so deep that they're going to cut off the nerves, and so that's why you don't feel pain. And so it's so deep that you're going to have damage to fat, muscle, and bone. So that is everything about types of burns that I would say you guys need to know. I don't have anything else other than that. So then moving right along. So I feel like I have a lot of random things on my notes about burns that are highlighted. So I'm just going to say some of these things that you guys can write down if you don't already have it down. But it's just kind of nice background information to know about burns. So first off, systemic results from burns, that happens when more than 25% of the surface area is burned. So that's when we're going to start seeing issues like all over the body rather than just like in that localized spot. And so that's important to know. I have lots of statistics. I don't really think any of this is super important other than maybe, okay, so I have bolded, so the temperature of the burn, the duration that you're burned, and the type of tissue involved, so that determines the severity of the burn. So those are all three things that as nurses we want to understand and we want to know when we're assessing burn patients, because it's really important to understand like how severe the burn is so we know what to do to treat it. I'm just making sure there's nothing. Yeah. Okay, so now we have like, okay, I guess these are types of burns too. Like before we were talking about like the types of burns, like the classifications of burns. This is like the types of burns, like how you get the burn. And you definitely need to know this as well. So first we can have a chemical burn. So that would be from like an acidic or an alkalized substance. And so this can affect the skin, it can affect the eyes, it can affect the respiratory system if we inhale it, and also systemically, such as like with the liver and the kidneys. Nursing interventions. Pay attention to the nursing interventions that I say for each of these because I can almost guarantee you will see at least one of them on your exam. So with a chemical burn, the nursing intervention that we're going to encourage is that you wash out your eyes with water or saline. And that makes sense. If you guys all think back to when you've taken like a chemistry lab, just think about how they always talk about the eye wash station and how if you ever get a chemical in your eye, you're immediately going to go wash it out. So if we ever have somebody with a chemical burn, we want to make sure that we get them to wash out their eyes because it could potentially be there as well. Next we have electrical. I feel like this is the one that we had a question on. So electrical burns, one thing to keep in mind with this is that fat and bone offer the most resistance. So nerves and blood vessels, they're the least resistant, and so they're going to be damaged easier. And so that's why with like electrical burns, fat and bone aren't always affected, whereas like your nerves and your blood vessels are going to be. The biggest thing, remember this, I think this is where we had the question about, the biggest thing with electrical burns is you're worried about dysrhythmias. And so you want to make sure that you're watching the cardiac rate and the rhythm. So that means you're going to put your patients on continuous telemonitoring because we want to be able to see if they have any of those changes. Next we have smoke and inhalation burns. So this is like hot air, steam, smoke. Biggest one I have highlighted is carbon monoxide. So remember this, I know we had a question on like the signs and symptoms of carbon monoxide poisoning. So carbon monoxide poisoning causes hypoxia and cherry red skin. I remember we had a question on the cherry red skin because I don't know why, like I just wouldn't picture somebody with carbon monoxide poisoning as having cherry red skin. But I definitely remember that. So just know that carbon monoxide poisoning causes hypoxia and cherry red skin, and the treatment is 100% humidified oxygen. Very important. The other thing to remember with smoke and inhalation burns is there's a very high risk for respiratory complications. So just like think back to all your nursing interventions about respiratory. So think about like what we're going to do if if we think there's a respiratory compromise. So we're going to watch their vital signs. We're going to watch for a change in LOC. If you have an inhalation injury above the glottis, we're worried about obstruction. If you have one below the glottis, we're worried about pulmonary edema and ARDS. Other burns, so like radiation, thermal, so thermal would be heat or cold, so like fire, frostbite, that sort of thing. So yeah, okay, sorry, I had to go take care of something, but so those are all of the types of ways that you can get burns that I would know. So like I said, like chemical, no, we're concerned about the eyes and we want to wash out the eyes with water or normal saline. Electrical, we're worried about dysrhythmias, so we want to watch cardiac rate with telemonitoring. And then smoke and inhalation, know those 2 signs of carbon monoxide poisoning and how we treat it, and how they're at a high risk for respiratory compromise. And then, yeah, so that's probably the biggest things I would know there. So another thing that I would take some time to study is who gets transferred to a burn unit. And I know Dr. Schneider spent a good amount of time on this when we did this unit. So not just everybody is going to be transferred to a burn unit that has a burn. There's lots of qualifications that they have to meet and like standards. So first off, we're going to look at the depth of the burn, the extent, the location, and the patient risk factors. So obviously, like if it's a deep burn, if a patient has a lot of comorbidities, so maybe they're obese, have hypertension, those patients are more likely to go to a burn unit than somebody who's just like a healthy 20-year-old who, has a really bad sunburn. Like that person probably isn't going to go to a burn unit. Additionally, somebody that has a partial thickness burn greater than 10% is going to go to a burn unit. Anybody that has burns on the face, hands, feet, genitalia, perineal area, and major joints, so like the knees, hips, they're going to go to a burn unit. That's important to know. 3rd-degree burns of any age, know that. I mean, you should probably know all of these. I can't remember if we had a select all that apply, but I definitely think there was a question where it gave you a couple scenarios and was like, who should go to the burn unit? So it doesn't matter how old they are, even if they're a child, if they have a 3rd-degree burn, they're going to go to a burn unit. Anytime you have an electrical, chemical, or inhalation burn. And so that's why I spent a little more time on those 3 and had those nursing interventions, because those people are always going to go to a burn unit because you're worried about respiratory issues, and like with the electrical, you're worried about the heart, so you want to get them to a burn unit so they can have more monitoring. This is kind of like what we just talked about. So any burn injuries with individuals that have previous chronic illnesses or like multiple comorbidities, and the reason why is because they're prone to more complications along with prolonged healing and an increased risk for infection. Burn injury in children, they're going to go to a burn unit, and I feel like that's pretty self-explanatory because kids are so small, and so a burn can greatly impact them a little bit more than you and I because we're older. And then burn patients who require special social, emotional, or long-term rehab are also going to go to a burn unit. So I would just understand those. That way, if Dr. Schneider posed a question and was like, which of these patients should go to the burn unit, you're able to understand that. So yeah. Next thing that I can guarantee you will be on your exam, and will probably be on the NCLEX as well, because I have had this on several practice exams, is total body surface area calculations. So this is that rule of 9s, and I feel like we did this with patho, but I can't remember. So rule of 9s is how you're going to determine the amount of fluids that you need in the first 24 hours. And so that's why we do this, is because it's going to tell us that fluid rate that we should do. So the different numbers that you should know is that the head and neck is 4.5%, and then the back of the head and the neck is 4.5%. So that means that if you have somebody that has burns on the front and the back, they're going to be 9%. the front of the trunk is 18% and the posterior trunk is 18%. So if you have somebody that has burns on both the front and the back of their trunk, 36%. The front of one arm is 4.5%, and then the back of one arm is 4.5%. So that means that if you have a burn on the front and the back, that's going to be 9%. Or if you have the burn on like the front of both arms, or if you have it on the back of both arms, that would also be 9%. If you have it on the front and the back of both arms, then that would be 18%. The front of one leg is 9%, back of one leg is 9%, so then front and the back of one leg is 18, front and the back of both of them is 36, and then the perineum is 1%. Definitely know that because I know you're going to have a question where you have to calculate that. So then let me find the fluid therapy section. Okay, so going off of the rule of nines, we're going to talk about fluid therapy because, like I said, the rule of nines, that's how you figure out the total body surface area that has been burned. And so you're going to use that in calculating how much fluid we need to give. So the formula, which you also need to know this, is going to be 4 times their weight in kilograms times that total body surface area. So that is like the rule of nines. And that is the total number of fluids that we need to give within the first 24 hours. So that's very important. So you're going to give half of that in 8 hours, in the first 8 hours, a fourth of that in the second 8 hours, and then the last fourth of that in the last 8 hours. So it should add up to 24 hours. Definitely important. I know we had a question on that as well. So, and that being said, we use lactated ringers for that initial fluid, not like normal saline. And that's just because lactated ringers can help with like rehydration and the electrolytes a little bit better. So know how to calculate that rule of nines, and then know that that calculation is going to be 4 times their weight in kilograms times that rule of nines number you get. That's how much fluid we need to give in the first 24 hours. Give the first half in the first 8 hours, first half in the first 8 hours, 1/4 in the second 8 hours, and then the last fourth in the last 8 hours. As far as fluids go, we're going to do 2 large bore IVs for if they have a total burn area greater than 15%, and we're going to do a central line if it's above 30%. So that's important. And the thing that we're looking for when it comes to fluids, and I also feel like this was maybe in the same question or just like somewhere on the exam, is how we know that we've met accurate and like adequate fluid needs is if someone is maintaining urine output from 0.5 to 1 milliliters per kilogram per hour. We also want to maintain a MAP above 65, systolic blood pressure above 90, and a heart rate less than 120. So that is everything with fluid therapy. So now we're going to backtrack a little bit. So now we're going to talk about the phases of burn management. This is important to understand, and this is where we'll talk about all those nursing interventions. So the first phase is the pre-hospital. And so this is obviously like before you get to the hospital, as the name entails, and this is going to be when the patient first has that burn. So the important things here are going to be like removing the patient from the burn, stopping the burning process, and assessing those ABCs. And we're also going to remove the clothing and jewelry that they have on. So the nursing interventions that are important for this stage would be to use a cool water dampened towel quickly on small burns. Larger burns, we're going to put a dry sheet over them to keep it warm. And then we're going to remove the chemicals from the skin, remove contaminated clothing, and flush with water. And so this is where like we talked about with chemical burns, like flushing the eyes. And then we're also going to treat with 100% oxygen. So then the next phase is the emergent and resuscitative phase. So this is the first 24 to 48 hours after the burn, and it's usually either in the ER or in the ICU. So we're worried about fluid replacement. So this is where we're going to start an IV within 60 minutes of the burn. That's very important. We're going to monitor their INO, and we're going to use that calculation that we just talked about to calculate the amount of fluid that they need and how much they're going to get in those 8-hour increments. Airway management, we're always worried about airway. I mean, that's the first A in the ABCs. So we're going to worry about it, especially if they have that inhalation injury or like an inhalation burn, or if they have a thoracic burn. Usually we're going to have them on some sort of O2 therapy, might even be intubated, but we're going to look for airway swelling. So that's your A and your breathing. So then your C is your circulation. So obviously we want to prevent hypovolemic shock, and so we're really worried about that IV fluid replacement. And so that's what we just talked about with like calculating the amount of fluid that they need. I feel like I've said that so many times, but it's so important. And that's why we're going to start that IV within 60 minutes of that burn. One thing relating to circulation that I know we had a question on is about how, so if someone has a circumferential burn, so a burn that's like around their entire extremity, that puts them at risk for compartment syndrome. So you're going to be worried about your 5 Ps, which you might remember from Adult Health 1. So that's pain, pallor, pulselessness, paralysis, and paresthesia. So if a patient has those, we're worried that they're going to have compartment syndrome. And you always, 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 always want to report no pulse. So if you feel that pulse distal from the burn and there's none, then like that's an emergency. So I would remember that. Remember that if they have a circumferential burn, you're looking for those 5 Ps because they're at risk for compartment syndrome. Other things we're going to monitor in that emergent stage is going to be pain management. We're worried about preventing infection, so we want to maintain body temperature, perform careful wound care, and they might need an NG tube to get adequate nutrition. We want to monitor their INO, so their urine output, I told you, should be like 1 to 2 milliliter per kilogram per hour. So in general, that should be about 30 to 50 milliliters per hour. If myoglobin is present or they have an electrical burn, then that urine output should be 75 to 100 mils per hour. They also might need a Foley to monitor that INO, so that's something to keep in mind. We are also going to be monitoring their labs in this stage, so hyperkalemia and increased myoglobin are possible due to hemolysis of the blood cells. So if you just think about it, like a burn destroys everything, so it's going to destroy those cells, which is just going to like explode, kind of like tumor lysis syndrome that we talked about with cancer, and how just like everything gets released. So you might also have increased H&H, so hematocrit and hemoglobin, because of the damaged red blood cells, hemolysis, and decreased fluid. So I remember when I first heard that, I was like, well, if they're dehydrated, wouldn't they have like low H&H? I don't know. It just like didn't make sense in my mind. But if you think about it, if they have decreased fluid, then it's going to be really concentrated. And so that's why you're going to have that increased H&H. So then the next stage after the emergent resuscitative is the acute phase. So this is when they're like hospitalized. They're going to be either in the ICU, burn unit, maybe another unit. And so this begins at the end of the emergent phase and lasts until all full thickness burns are covered with skin grafts or partial thickness burns are healed. So that's important to remember because that determines like when they're out of this stage. So wound covering and care takes about 21 days. Obviously, it depends on the person, it depends on the situation, but in general, this phase is going to take about 21 days. This is where we really start to worry about like protein intake and increasing that because we want them to be healing as quickly as possible. So we might even start them on IV albumin to get that protein intake up and make sure that they're having adequate healing. Once again, we're worried about fluids, so looking at their lactated ringers, looking at that fluid rate. We're also worried about infection in this stage because this is like the heart of the healing stage, and so they're really like prone to infection. So remember your signs of infection like purulent discharge, odor, extreme redness and pain. So we're monitoring for those signs and symptoms and reporting any of them. We're worried about edema, blood pressure, and a pulse ox because we want to have them on that for cardiac status. Once again, worried about that airway edema, and so you're going to look at their respiratory rate. Are they going to need to be on O2, a vent, those sorts of things. We're also worried about hyperthermia during the metabolic stage due to the hypermetabolic stage. And so they can actually develop a low-grade temperature to, basically because hyperthermia due to the hypermetabolic stage, and so your body's going to try to compensate. That's the word I was thinking of. Your body's going to try to compensate, so you could potentially have a low-grade temp. So that's why, I think I mentioned at one point, you're worried about their temperature because they have, that ability to fluctuate, high and low very, very quickly and very easily. So, one moment they might be hyperthermic and one moment they might be hypothermic. So, very important to keep an eye on that and do your vitals accurately. Pain management, as always, we're also worried about psychological care, PT, potential complications that can happen during this phase. So obviously we're worried about aspiration, especially if they have respiratory issues. And so this is where, that NG tube might need to be in place. They also might have a lack of GI motility and issues with drug metabolism because of if they have a burn, especially to that area. And so this is important. I feel like this popped up somewhere. So we want to use IV drugs for burn patients whenever possible. So if there's an IV form of a drug available, we want to use it because we want to ensure that they're getting those drugs because a burn can decrease your drug metabolism. And so if you give it PO, there's a chance that they might not get the full effect of it. We're also worried about ulcers. So we're worried about an ileus, diarrhea, constipation, and Curling's ulcer, which is just like GI ulcers. So we might give PPIs and H2 receptor blockers. We might have to, like I said, put a straight cat or put a Foley in or straight cath them to manage that INO accurately. And we're also worried about kidney function, so watching those kidney labs. So then the last stage is the rehabilitation phase. And so this begins early in hospitalization and can take up to 2 years. And so this is when we're really trying to reduce scars and contractures. I have that bolded. That's the main point of this stage. So we might put compression sleeves on, pressure dressings to prevent contractures and minimize scarring. We also want to maintain proper body alignment, splint extremities, and help them change positions to prevent those contractures. I feel like those 3 points are really important. And like I said, I feel like we had a question on this stage and what it's trying to accomplish. Like I said, though, this can take years. We want them to ambulate as soon as possible with PT and OT to help maintain their joints and their range of motion. Neutral positions and functional positions, like I said, to prevent contractures. And we want to monitor for pressure ulcers, and they might even need surgery. So those are all your stages. So now this last little, yeah. Okay, so I have notes on a bunch of different things nursing intervention wise that we're watching, and so these kind of go into those different stages. So the first thing I have here is about fluid and electrolyte shifts. So we talked about how we're monitoring those electrolytes after a burn because since they have that hemolysis of blood cells, we're worried about hyperkalemia, increased H&H, that sort of thing. We're also worried about hypovolemic shock. That's the greatest threat here. And so hypovolemic shock can begin as early as 20 minutes after a burn. And so you want to make sure that you're watching for those signs and symptoms. Increase in capillary permeability causes a rush of water, sodium, potassium, and proteins out of the vessels into that interstitial space. So that's what we talked about with monitoring those labs. Second spacing is your fluid to the interstitial space, and third spacing is your fluid to the exudate and blisters. So that's in non-fluid storing locations. We talked about hemolysis, so that can cause that increase in H&H. So then as far as a little more specific about your electrolyte values, so you can have hyponatremia as fluid shifts. and so the water dilutes. You can have hyperkalemia. You can also have hypokalemia if you're vomiting or having like excessive diarrhea. And then one thing that's really important to keep in mind with burn patients is we want to be monitoring their blood sugar as well, because if we have elevated glucose, that's going to put extra stress on the body, and so it's going to like make the healing process a lot harder and a lot slower. So that is what I have for fluid and electrolyte shifts. So then the little section here is on inflammatory and healing. I mean, not really anything crazy here. So wounds attempt to repair themselves within 6 to 12 hours. You can have coagulation necrosis if there's injury to tissue and vessels. And then compromised skin, bone marrow depression puts burn patients at that increased risk for infection, which we already talked about. We already talked about fluid therapy. So then wound care is a really important thing with burns because obviously they have wounds and we want to limit that infection risk and make sure that they're getting cleaned and taken care of appropriately. So there's lots of different methods that we can use. We want to make sure that we're following the orders that the doctors have put in for wounds and that we always work with like the wound care nurse, because they're going to be so much more knowledgeable and just so much more educated on the proper ways and what we should be doing. So just keep that in mind. This can be really, really painful for patients, so you want to think about pain management and giving them pain meds before you start. That's very important. I have that bolded. So the important thing here is that we do once a day showers and twice a day dressing changes because we want to keep those wounds clean. Dressing changes always, always, always should be sterile. Very important. I feel like that'll pop up somewhere. So if we have an open wound, it typically only uses topical antibiotic if you use that open method, but closed, we're going to put sterile gauze over an antibiotic gauze. Sterile gauze over antibiotic gauze or topical antibiotic. Like I said, we're going to be changing those dressings like twice a day for several weeks, and we want to make sure that we're using the proper PPE when we change them. Patients might also get debridement, which is when we clean out a wound. So mechanical would be like, for instance, with using your hands. Hydrotherapy would be with water. There's also surgical debridement, things like that. But the biggest takeaway is to remember that you want to give your patients pain medication before you do anything related to wound care, and that you're encouraging them and like making them get cleaned up at least once a day, and then changing those dressings like at least twice a day, and that they're sterile. So like I talked about, we're worried about body temperature because burn patients have that ability to fluctuate a lot. And so one thing that I have that's really important and I feel like popped up is that room temperature should always be at 85 degrees for burn patients to prevent infection. And I've been in rooms in barns that are 85 degrees and it's not fun, but you got to do what you got to do to keep your patients safe and to make sure that they get the best care that they need. Yeast is the most common fungal infection that we see in burn patients. We can manage that with Lactinex, which is like a method that helps to reintroduce normal flora to the GI tract. We also have skin grafts that we can use. I don't really remember there being anything on the exam about skin grafts. But like an autograft would be a permanent graft. Artificial skin is also permanent. We can use an allograft or a homograft from a cadaver. And then heterograft or xenograft is temporary. But like I said, I don't really remember there being anything on grafts. So just remember those important things I said about how like we keep the room 85 degrees because we want to decrease that infection risk. We always want to do those sterile dressing changes at least twice a day, wearing the proper PPE, and getting them cleaned up at least once a day, and the pain management. And this last little, oh wait, no, there's 2 more sections. So then the next one I have is drug therapy. I don't have much here. So Analgesics, obviously very important. We're worried about pain. And once again, I have this highlighted. Remember that opioids, any drug you can give IV, you want to give IV to make sure they're getting that full effect. Tetanus immunization might be possible here, depending on where they got their burn. And then also remember, we're worried about DVT prevention. So remember, like, we might give enoxaparin, for instance. One thing though that I do have highlighted is this antimicrobial creams. So we use silver sulfadiazine. Remember, I'm terrible at pronouncing drug names. That's never going to change. So Silvadene, I know it by that. So this is a cream and silver impregnated dressing that we place for 3 to 17 days. And we want to make sure we monitor patients for if they have a sulfa allergy. So that's what I have for drug therapy. And then this last little section here is nutritional therapy. So remember, we want to make sure our patients are getting accurate nutrition, especially protein, because that's really important for wound healing. And they're going to have an increased metabolism with this wound healing, so they're at risk for losing weight and just like becoming really like unhealthy. So your patient might shiver because of this increased metabolism, and there can be elevated levels of lots of things. So like your steroids, glucagon, and so that increases oxygen consumption and heat production. And remember, this prolongs that healing and infection risk. I have this highlighted. The goal is to prevent catabolism. So we want to maintain sufficient caloric intake and protein intake to restore tissue loss, because we don't want them to lose anything that we can prevent. So the total caloric needs, this is important, we should aim for 3,500 to 5,000 calories a day. So 20% of that should be protein to help with wound healing. 50% should be carbs, because that'll replace that need for energy and then like prevent any catabolism. And then 30% of that should be fat. Like I mentioned earlier, we might need to give them an NG tube to maintain this caloric intake initially. So if that happens, the feeds should be about 20 to 40 milliliters per hour via NG. That's important. And then we're also going to make sure they're getting all the adequate vitamins and minerals. So I have C, A, zinc, and iron are important. So vitamin C, vitamin A, zinc, and iron. And then, okay, so I guess I have one more little section here. So then this other thing I have is about patient and caregiver support. So burn patients obviously require lots of care, like round-the-clock care. I mean, just think about how you're doing your wound care like twice a day. You're showering them at least once a day. Like, they can't really do much. They need adequate nutrition. Like, there's just a lot involved in their care. And so one thing that we're really worried about with burn patients, like we are with any chronic patient, is compassion fatigue. So this could be for the caregivers that are at home. It could be for the nurses, but basically compassion fatigue, because we're spending lots of time with these patients and they require lots of physical and emotional demands. And so that bond with the nurse, patient, and family can become very strong over time. And so like you can just feel fatigued and just feel like you're not doing enough. You might feel like you're not important in their care, because like burn patients, it's going to take a while to see recovery. And so it's really important to do stress debriefs when it's needed. So like if you start to feel fatigued, if you start to feel like psychologically you're in a different place, or you just are having like more emotional demands. So that's really important to monitor for nurses that are taking care of burn patients. But it's also very important to monitor with like family members, because obviously once this patient leaves the hospital, they're still going to have a lot of needs. And so we want to make sure that that family member is in a mental state where they can take care of their family member. And then the last little thing I have about burns is just remember your older patients are more at risk for like injury from burns. They're more at risk for like chronic illness, comorbidities, so they might have prolonged healing. So yeah, that is everything that I have on burns. I really feel like it wasn't a ton of the exam. I mean, burns and musculoskeletal are definitely like the two bigger parts, and then not as much with critical care. So I would just remember like your types of burns and like those little characteristics that I named about each one. I would remember like what can cause burns and those nursing interventions. So like chemical versus electrical versus blah, blah, blah. I would know who is transferred to a burn unit, so those characteristics, know your total body surface area calculations, so your rule of nines, and remember that you then use the rule of nines with the Parkland formula, so that 4 times their weight in kilograms times the surface area to figure out that total fluid need for the first 24 hours. And then I would know your stages. Some nursing interventions that go with each, and then those nursing interventions for each of those areas of care that I talked about. But that is pretty much burns. So as always, if you guys have any questions, feel free to let me know. I will be doing your musculoskeletal review here pretty shortly. I know I said I was going to do it either Saturday or Sunday over the weekend, and I was like, well, that's probably not a good idea because I know you guys just had like an introduction and you were going to be finishing it this week, and so I wanted to wait until you went over everything. That way I didn't have to make like 5,000 different videos. But as always, if you have any questions, let me know, and happy studying and enjoy your weekend, guys. Thank you.